There are multiple technologies capable of detecting TRK fusions. You can look for TRK fusions at the DNA level, and that's what most next-generation sequencing tests do. You can also look for expression at the RNA level, and there are now commercial-grade assays that can do detection at the RNA level. And you can also look for expression at the protein level by immunohistochemistry. On top of that, there are some orthogonal assay or approaches like FISH, which have been used historically to detect other kinase fusions like ALK, which can be employed in a directed manner. The really important message here is that there is no single perfect test for detection of TRK fusions. There are particular challenges with detecting TRK fusions in a purely DNA-based tests. These fusions typically involve the introns of genes, and the introns of NTRK2 and 3 are quite large, and that can make it difficult to detect TRK fusions. RNA sequencing is, of course, an excellent way to detect TRK fusions, but doesn't have the same penetrance yet in the marketplace that DNA-based tests are, and they obviously can't necessarily detect other coding mutations that we can readily detect by DNA. And then immunohistochemistry is also potentially a very good test, but due to the number of tissue types involved, there is always the possibility for normal TRK expression in certain tissue types that are not caused by an underlying TRK fusion. So what we're really in is a situation where the physician needs to be aware of the test they've ordered and whether it has the ability to detect a TRK fusion. And what I can really just say at this point is that if they want to know, they may have to pick up the phone and speak to their pathologist or call or look on the website of the company. And if they have a particular preferred vendor, they only need to do that one time. And I think it is important because some of these tests, physicians are asked to fill out these requisition forms. There's multiple check boxes. They need to find the check box that says, I want to look for fusions in my patients, depending on the assay. So unfortunately, this is a diagnostic area which is going to require education of the oncology community over time.
I think there's debate right now in the community about how valid and cost-effective is widespread testing. And there's some data out there that there's only a handful of truly actionable molecular alterations. But I think that what that criticism forgoes is the fact that we are making progress almost every year on this area of precision medicine. If larotrectinib is approved, it'll be one of many other, hopefully, other possible tumor-agnostic precision indications that will come in the next several years. And so I think as we move forward in the context of precision medicine and oncology, I think next-gen sequencing or profiling will become increasingly more important. How next-gen sequencing will impact rare tumors versus more common tumors, I think it will definitely have a much more direct impact with rare tumors. Oftentimes these rare tumors do not have options other than surgery, other than maybe some radiation. They often may not respond to chemotherapy, and so if these alterations are present and actionable, this may be a really good option for these patients if there's evidence that they have activity in the clinical trial setting. For more common cancers, again, I think it will just depend on what the data shows in further studies down the line. Obviously, for many common cancers, for example, lung, we now know that immunotherapy plus chemotherapy has significant advantages and benefit in these patients. If the patient had an NTRK fusion, for example, would I give them an NTRK inhibitor before that immunotherapy combination? Probably not. But if they had no other alterations and they progressed on that combination, I would probably prescribe larotrectinib right after that. So much of this, I think, is really tumor dependent, and to what extent, first line, second line, third line therapy, what overall benefit those therapies have relative to some of these, such as larotrectinib. With that said, larotrectinib, even given the small number of patients we've had in lung and in colorectal, have shown durable responses, have shown durable benefit in those patients who do have NTRK fusions, even in aggressive tumors like pancreatic. We've had only a handful of those patients, but they've had significant durable responses and benefit in those patients.
One of the features that we've seen with patients whose tumors harbor TRK fusions is that these fusions appear to be clonal events. And what I mean by that is that they're present in every cancer cell at every time point and at every site. And as a result of that, it really doesn't matter which and when you test. So if you can test the patient's primary tumor, you can test a metastatic site. What's really critical is that you perform the test at a time when the turnaround time of the test doesn't prevent, or is not too long to prevent, use of the information should a TRK fusion or other actionable alteration be identified.